0.25, is that right? Okay. Am I on the microphone? Okay. So I gave you a FAFI of a gas that was 0.25. Blood gas of 0.25, great. So lambda was 0.25. And I asked you to, at equilibrium, to guess where it was, or to estimate where it was on the FAFI curve. Okay? So let's think about this. Whenever you have this and you're not sure of it intuitively, draw this out. Your alveolar unit and your capillary. All right, what am I saying about this right here? First off, what can you do to any number? You can put it over 1, and it's still the same number, right? So this is a blood gas. And we can look at it, 0.25 over 1. So for every 0.25 parts in the alveolus, there's 1 part in the blood at equilibrium. Blood, oh, flip them. Blood gas. So for every 1 part in the, blood gas. For every 1 part in the gas, there's 0.25 parts in the blood. There we go. How many total parts do we have? We have 1.25 total parts. Okay, what have we inspired? We've inspired 1.25 total parts. That's your FI. Right? And so now, what's your FA? So, if now 1 over 1.25 is equal to my FA at equilibrium over FI. So what does that equal? I think it's 0.8, is it not? So that's where that came from. That help? Yeah.
I have a question.
Okay.
So when we're looking at the FAFI and we go to point B, which is the knee or whatever, which is what we were talking about.
Check.
So
the knee right about here.
The lambda being 0.25.
Okay.
Am I correct in thinking that basically point B is approximately 3 tau? So if I take that 0.25 and multiply it by 3, which I get 0.75, or is that just, I got lucky on that one?
I think you got lucky on that one. That's a connection. I understand where you're going with it, but that'll get you in trouble.
Okay.
All right. All I'm saying is that at an appropriate equilibrium, about 0.25, this knee starts. And this isn't drawn to scale. I'm going to put not to scale. All right. All I'm saying is that when there's an equilibrium on the FAFI curve, and I said it wrong, at 0.8, so this curve actually would start bending way up here, right? It would start bending way up there. That thing you did and got lucky, I think, yeah, come see me because I have no idea what you're talking about. All I know is that at equilibrium, that's where many experts agree that the bend starts. And so that point there is 0.8, high up on the curve. It's helpful? Okay. Other questions on the calculations? So far, we're just keep trying. I sent out, I was going to go over it in class, but I think we'll nail it enough in the quizzes. I sent out a few slides to kind of give you some examples. You've all been back now. You can look at that slide now and visualize the machine and say, okay, purple is ISO, yellow is SIVO, blue is DES. I've got my controls. and take those slides and make your own numbers, make your own problems. And if you don't think it's right, I'll check it. Right? Check it. And I'm not perfect, obviously. Duh. I can't believe I made that mistake. Such a common mistake. Anyway, we've been talking a lot about MAC. A lot about MAC. It's what drives what we administer. It's our dosing guide. Now we have to understand why we deliver it, how the circuit's affected, how the flow's affected, how the body takes it up. We're starting to get an idea of that. We're not experts. But now there's patient conditions that will also lower the concentration required to achieve MAC. And if you get in the habit of always referring to MAC as a concentration of an agent, you'll never look at the dial and think that that's MAC on the dial. You'll always remember that it's a concentration. Now let's go through these conditions that can lower what you need to keep someone still. Hypothermia. So I'm getting cold. Stacy, what does cold do to nerve function? It slows it down, right? Anytime you decrease metabolic processes intracellularly, you create resistance in nervous tissue. And if you create resistance in nervous tissue, you are going to hibernate, quote unquote, the nerves. And therefore, you don't have to give as much drug to further decrease nerve transmission. Pregnancy. For those who have been pregnant, you may have experienced this, but you make this steroid called progesterone. And that also has a local anesthetic effect. It decreases nerve transmission. If nerve transmission is decreased, right, you are already somewhat sedated. So that will decrease your concentration required to achieve MAC. Progesterone. Mm-hmm. Age, being older. There is an approximation that I've come up with about organ function after the age of 40. And in my estimation, based upon several calculations I've seen, it's about 1% per year after the age of 40 decline. So if you're 80, how about you, and what do you think, according to that calculation, it's a nice rule of thumb, not exact, but it helps. What do you think your nervous system is doing? Is it more efficient or less efficient than it used to be?
Less efficient.
Definitely less efficient. And if your nerve transmission is less efficient, you don't need as much drug to give you an anesthetic. Hypotension is an awesome anesthetic. If you can't deliver oxygen to the brain, you can't have any excitatory neurotransmission. Hypoxia is an awesome anesthetic. If you become hypoxic enough, it's to the point where your PaO2 is actually beginning to drop now, you can't provide substrate to nerve cells. Nerve cells can't undergo metabolism and can't create the neurotransmitters necessary for nerve function. CO2 levels above 95. Who here has had a patient that you had to call in respiratory distress when their CO2 went up to 100, 110, and they began to hypoventilate? CO2 will cause a narcosis-like state, acidosis. Acidosis. What happens to enzyme activity as you begin to approach 7.1, 7.0, 6.9? It slows down and it stops. Enzymes are in nerve tissue. Without enzymatic function, there is no metabolism, and your nerve function decreases. If you add electrolytes like magnesium or lithium, have you learned about the Nernst equation? And you've learned about the electrochemical gradients?
Yeah.
So if you can put ions in there that disrupt that electrochemical gradient, you're going to create resistance and halt nerve function. Thereby, you don't need as much stuff to put patients to sleep. Hematocrit should speak for itself, kind of like hypotension. Acute alcoholism. If somebody's just had a fifth of whiskey, I don't have to give them very much anesthetic. But if somebody's a chronic drinker and they come in sober, I'm going to have to give them a lot of anesthetic. Marijuana, of course. Nitrous, you all know that it's additive when it comes to MAC. Local anesthetics, decrease nerve transmission. Induction agents. Does anyone, we're not there yet, but 4 of your induction agents work on this receptor. Anyone have an idea? GABA, the GABA receptor. And when you open up that receptor, what happens? Chloride goes where? Intracellular. That creates resistance in neurons by making a hyperpolarized state. It's going to decrease nerve transmission. Opioids, the same thing, as well with alpha-2 agonists. So hopefully you guys have started touching on the GS, GI, GQ proteins and you understand those mechanisms. Now things that increase MAC. If you're a red-headed Irish Eskimo, probably going to take more gas to put you in a state of anesthesia. Redheads have their rapid acetylators. They chew things up quickly. Certain Irish populations are rapid acetylators. Asian persuasions, 80 to 90% of that population are rapid acetylators. And the Eskimos, on that context, 80 to 90% are rapid acetylators. So if you're a rapid acetylator, you eat things up quickly. Hyperthermia. Hyperthermia increases your metabolism. When your metabolism increases, your needs for an anesthetic will also increase. Not necessarily neonates, but toddlers definitely have a higher metabolic state and need higher concentrations. We talked about the chronic substance abuse in regards to alcohol. And drugs that will increase catecholamine release will also make it harder for you to achieve MAC. Because if your sympathetic nervous system is stimulated, it is hard to quiesce that. Okay. Any questions on what increases or decreases MAC? Those make for nice test questions. One thing I want to say about nitrous that I haven't said. It gets a little disjointed, just bear with me. Nitrous has a great analgesic effect to it. I've read some papers that say you can give 70% nitrous and achieve the same effect as 4 to 5 milligrams of morphine. I've also read that that effect can be as high as 7 to 8 milligrams of morphine. The point is, when you're running it, you get an analgesic effect. All right? But when you turn it off, that effect goes away.
Is there a mechanism behind that?
It might be related to the release of nitric oxide when it dissociates in the body. Now you can fly through the next couple of chapters because honestly I forgot why I put them in there. All right, let's get to the physiological effects of the... Yes, sir?
So just a clarify, so the other inhalation agents don't have the analgesic quality that Nitrous does?
You will read most recently that it has very, very little analgesic properties. In fact, in my opinion, it has 0 analgesic properties. However, there is literature that says it has very, very small amounts of analgesic properties. And you can see possibly how that could be. Activating a GABA receptor, for example. What's that? What is that theory? If it's the GABA receptor, the 5 angstrom theory, right? Because the pore of the GABA receptor is 5 angstroms. So you can see whether if you activate that and you increase GABA neurotransmission, you might decrease nociception. Are you all familiar with that term? Nociception. Just to reiterate, yeah.
So from based on that, you're saying it has analgesic effect, nitrous?
Nitrous does have analgesic effects.
Okay. What were you saying that some of it is very small?
Isopseboic
Oh,
gas.
yeah.
Excellent. That's what I need. Keep me in check. Okay. Because I know what I'm thinking, but you don't know what I'm thinking. I want to just re-stress the immobility part here. This was taken from Dr. Rampel's paper, and this just stresses the fact that you can cut off circulation from the spinal cord and the body to figure out that if you want someone not to move, that is mediated at the spinal cord. I don't know why it's specifically related to the spinal cord. I just know because of this experiment, they did a nice job showing that the reason you do not move is because of the effects of the gases on your spinal cord. On that same note, it's very clear that the reason you don't remember is because of the effect of the gas on the hippocampus. I don't care that you necessarily know the CA1 region, but if you can tell me hippocampus, anesthetic agents, decreased memory, I'm happy. Do not worry about the word non-immobilizers. If you're reading text and you read about non-immobilizers, those are other small molecules that will cause amnesia, but not cause immobility. So they'll work on the brain, but not on the spinal cord. So the reason that you get amnestic might be a result of what theory based upon bullet number 2. Take a second, read that. It says, in summary, full anesthetics and non-immobilizers may produce amnesia by acting on a nonpolar site. And that nonpolar site would be the interior of the lipid membrane. So what theory are they suggesting is responsible for amnesia? The lipid membrane theory, which says that the gases get inside that amphipathic lipid bilayer, distort it, and reduce the function along that lipid bilayer. Tracking? You're going to get to phase 2, and you say that, and they're not going to have a clue what you're talking about. Your staff will be like, I don't care, what's the MAC? Okay. All right, I also gave you another file in your lectures that help summarize those graphs out of Barish. I looked at them and I said, man, they're messy. And you all understand what graphs are talking about? The effects at 1 Mach of mean arterial pressure, for example. And so what I did is I took the 3 agents that I want you to be aware of. I actually, to my best ability, mirrored up the numbers in those graphs and came up with these results. All right? So we're just going to start with the left tab and move over to the right tab. If I have 1 Mach of isoflurane, 1 Mach of desflurane, or 1 Mach of sevoflurane, and I am spontaneously ventilating, what will be my effect on my PaCO2? Okay, what will be my effect on my PaCO2? Well, what does this say? Decreases your PaCO2. Why might that happen? They do. That might be reversed. But you do initially hyperventilate before you hypoventilate. Let me just see that if I need to reverse it.
Yeah, it's like 134. Well, you added a couple extra slides.
That's okay.
Ours is 134.
Check.
Yeah, after that.
One more above. We're getting there. Yeah, you're right. PaCO2 goes up. Did I mislabel that tab? That's what I'm wondering. I believe I just put negative where it should be positive. So imagine, if you will, that this is plus 10, plus 15. In fact, I can't actually change that.
If you hit edit anyway at the top, you can, sir.
It would not be PaCO2 that you have, you just need to tab it.
Well, the effect is pretty much the same, though. They're all going to go up. So that would be the question. What is the effects of the inhalational agents at 1 Mach on your PaCO2? I agree. They all make them go up. There's no difference. There's no ranking. Don't get confused by those. They all do the same thing.
What's your y-axis?
Millimeters of mercury. This is right. Now, we're talking PaCO2 going up. That can only happen if one of two things happen, or 2 things happen. What are that? So tidal volume has to go down, or rate has to go down. So let's see what happens here. Well, at 1 Mach, I have the 3 modern agents, and I see that sevoflurane and isoflurane, they decrease tidal volume a little bit more than desflurane, but they all drop. Okay, they all decrease tidal volumes. Now, what about respiratory rate? Yeah, this is what I just flipped the, this should be actually reversed. That's what I did. So respiratory rate's actually going to go up in a spontaneously ventilating patient at 1 Mach. So what does that tell you? If tidal volume goes down, respiratory rate goes up, then what do you deduce by seeing that the PaCO2 also goes up?
Minute ventilation.
Overall, minute ventilation has decreased. So that tells you that your respiratory rate is not fast enough to account for the decrease in the tidal volume. All right? So if I have a spontaneously ventilating patient at 1 Mac and their CO2 levels continue to rise, and let's say, for example, you're in the field and you're running some isoflurane in the ICU because you're out of sedative medications. I'm creating a situation. You're out of sedative medications and you have a head injury patient. You don't have a vent, and now they're ventilating on 1 Mac of isoflurane. What do you think the CO2 will do to the head injured patient? Theoretically, in theory, the ICP could rise, right? But then you make a big stink and get them a ventilator on the unit, and what do? You control the CO2 to offset that. You might see that example again. Now let's look at the effects on the cardiac index. Cardiac index drops, but desflurane, there's a point here. Desflurane has this little property to it that the others don't have. If you're able to maintain hemodynamic parameters just a little bit better than something, what autonomic nervous system are you probably able to activate a little bit? The sympathetic nervous system. And that's a property of desflurane. It will actually have some catecholamine release. And this is, I'm looking at the cardiac index. Yeah, if you want me to, this is the cardiac index. It's, the reason I'm using these, they're much simpler than those slides that are on your slides out of Barish, because they just get ugly. So cardiac index. Now let's look at the units of heart rate and these 3 gases. Check this out. So I just told you that cardiac index drops with ISO and with SIBO, and it drops a little bit with DES, but not as much. And does heart rate influence cardiac index? Yes, it does. Absolutely. Look at this. So SIBO and ISO is behind it. It's in there. It just fell behind it. It drops at 1 Mac, the average heart rate, by about 2 beats per minute. Not a lot, but it drops it. Then you look at DES. Man, that increases it by 10 beats a minute. That's going to keep, actually ISO is underneath there, my bad. Let me make this 9 so you can see it. There you go. So ISO and DES, they increase the heart rate. But DES does it a little bit better than isoflurane. And anyone here followed anyone in the OR and they increased the desflurane? And for the next 30 to 40 seconds, seeing that increase in heart rate? Has anyone seen that? Sure. Because when you make those quicks, yes.
In those pictures here in PowerPoint, ISO has greater effect on rate.
Well, look where they all start. I put where they start versus where they end. They don't all start at the same place. All right. But I'm telling you, DES will increase heart rate. ISO will do it, but DES will do it as well.
So he's at 1.5 Mac. Just comparing the one you're looking at is at 1.5 Mac. It is consistent with the whole picture.
So now let's look at contractility. Doesn't really change. I wouldn't ask you anything on that. But this is minute ventilation. And we discussed PaCO2, we discussed respiratory rate, we discussed tidal volume. This is the effect at 1 Mach of minute ventilation. And you can see the clear delineation between the gases. So ISO, according to Barish, will drop minute ventilation at 1 Mach by 1 liter per minute. SIBO will drop it by roughly a half a liter per minute. And desflurane will drop it by roughly 0.2 liters per minute.
And that's all accomplished largely from the tidal volume decrease, not from the
Correct.
minute volume is going to increase. We know that that's partly in response to CO2, but it can't overcome it because of the
Tidal volume.
tidal volume.
Yeah, the rate's going to increase, but it can't compensate for the decrease in tidal volume. So now let's look at MAP. Given 1 Mach, they all drop the same. There's my question. CVP. Okay. I don't know of a time that I would use an agent to elevate or keep my CVP, but it's kind of a cool little thing to see. At 1 Mach, desflurane will increase CVP slightly by 1 millimeter of mercury. ISO will do it not at all, and at SIBO will drop your CVP by 1.5 millimeters of mercury. Okay. SVR. What's SVR a measure of? Systemic resistance, absolutely. Systemic resistance. So large vessels, and you see that your desflurane will drop your SVR, the greatest at 1 Mach. I'm a guy that likes highs and lows. If you know what something does the most and what something does the least, I'm good with that. You'll get those questions right. And then finally, stroke volume. Stroke volume, not a huge difference, but you see that the greatest decrease in stroke volume is with DES and the least is ISO. Now, we can go through these other slides, but I found over the last couple years that people were getting all hung up. Sir, are you talking about 2 Mach, at 1 Mach, 1.5 Mach? I'm talking at 1 Mach. I want you to know the physiologic effects of the agents at 1 Mach, according to Barish. The one thing I didn't have was the respiratory bronchial smooth muscle resistance. True or false? All inhaled anesthetics, DES, SIBO, and ISO, are bronchodilators. It's true. They all are very good bronchodilators. SIBO seems to be the best at accomplishing bronchodilation. So what is SIBO setting itself up as? It's setting itself up as a very good inhaled anesthetic for induction. It's sweet. It decreases respiratory vascular resistance. Right? Now, desflurane. You're going to say, sir, isn't that pungent? Yes. But it doesn't mean that if somebody is already induced and you introduce it to the bronchial smooth muscle, that it won't relax. The reason that you cough and you sputter and you spit with desflurane are these things called irritant receptors that are in your larynx, in your trachea, and that's what they're called. They're called irritant receptors, not very well identified, that appear to be activated by desflurane. And so when you begin to breathe it, you start coughing and sputtering and spitting because you are irritated. So if I ask you, which inhalational agent would you most likely hold your breath on, you would say desflurane. All right. take a break.
So when we come back, can you just do the coronary scale?
Yeah, I got to go back and find. I got to go back and hit those.
You just ask it.
When you see these automatically will update the websites and or did you see some changes on your PowerPoint slides? Will you automatically save?
I didn't change. I actually gave you the Excel file that I just showed.
Or did you make some changes?
Oh yeah, I'll fix that.
So I can print it out. So
So all the time you increase your rates, so it makes it really shallow. But you can counter that by giving opioids, right? To slow down your breathing but make your breath deeper. That's the only thing I really remember from shadowing.
But no, you're still not going to counter that stuff.
Right.
Because what's going to happen to your rate?
You're going to slow down.
Consider shifting.
Sure. Yeah. Because even if you're slowing it down, you take those breaths, it's still not, your minute volume is still not going to change.
And you end up with like a 55 CO2.
Yeah.
That's perfect for me, by the way.
So
If I have somebody spontaneously ventilating, my charge is 55.
Because that means they're breathing. That means that they're not as deep.
They're narcotized, they're breathing 8 to 10 minutes, they're something. That's my comfort level, is 55 CO2 and an 8 to 10 respirator.
Is there any patient where you wouldn't want that because, like, maybe if you're worried that much about their pH being off?
Oh yeah, there's definitely. I'm talking about just a black chole normal patient, you know, at the end. Yeah, but once I know that everything is stable, I'm looking at my wake up to be respiratory rate of 8, CO2 55.
Right. Versus someone who just resuscitated and had
They're not getting next to me.
that's not control interview.
Exactly. If they got a pH of 7.1, I'm not taking
So when you're listening to this, slide 119, slide 120, 121, 122, 123, 124, 125, 126 are covered in that Excel spreadsheet. I did make some changes, and I'll update it and make sure that you guys get it. I want you to know the high and the low. Except for the ones I said, really, there's no change. Yeah.
So when we're talking about the effects of all this stuff at one act, is it just for real world scenarios? Does it plateau out? Like if you're dropping your map, just at 6%, you're on one effect.
So in order to get cellular death, 4%.
Yeah.
3%.
You can plan on that.
And I'll make sure I go back and make sure the Excel files are correct. And I'll do a little word. I'll do a little bit of
7% dead is what give you
Triggered by that, like,
Yeah, it really is.
Justin, I'm going to do a word again on that. Make sure my Excel files are correct, and then I'll take 3 to 5 minutes physiological effects.
7% dead is just so you're always
So it's really good. Thank you. That's it. Every little bit.
It's a journey. Enjoy the scenery. It's a journey. Okay, so big points. Let's get going again. What do inhalational agents, assuming 1 Mach, do to respiratory rate? Increase. Yes. Mach. Decrease. Mach. Decrease. Yep. Decrease. PaCO2. Increase. Minute ventilation. Decrease. So those are big pictures. If I want to increase my heart rate, what 2 agents will increase heart rate? That's ISO. Nitrous. Well, nitrous will do it. It releases catecholamines, but it's not a volatile agent. So it's not a volatile agent. What if I want to, just for giggles, increase my CVP? Desflurane.
Give me some fluid.
Give them some fluid, but I'm talking inhalation. Right, so make up your own questions in regards to those physiologic parameters. I'm going to do another 5-minute vignette after I go back and make sure that I transcribed my Excel file correctly. And I'll do a 3 to 5 minute vignette on those physiologic effects and ask some of those questions and put some of those scenarios in there. So we'll definitely make sure you get that information. All right. This is another prototypical historical question that's going to come up. And every time I say isoflurane, you should say steel. Iso, steel. Iso, steel. When I say iso, you say steel. That's right. Why? Because in dogs, isoflurane can cause a coronary steal. Now, what is that? Well, we know that coronary blood flow is affected by autoregulation, and we know that autoregulation is affected by diseased vessels, right? If I've got a stenotic heart vessel because of a plaque or an occlusion or whatever, distal to that occlusion, and here it's represented by this blackness, this problem there. Everything beyond that is maximally dilated, right? It has no tone. And so the healthy vessels that are not diseased, they maintain a tone. And because they maintain some tone, we all know that we have some sympathetic tone in our vessels at rest, it's able to shunt blood past that occlusion, right? And that's how that occlusion gets blood past it, because the other vessels constrict and put some pressure on there. But we give inhalational agents, like when I say iso, you say steel, iso, steel, iso, steel. We give isoflurane. And in dogs, apparently, it will dilate healthy vessels. And when healthy vessels dilate, what happens to the pressure inside that vessel? It drops. And because it drops, is there now a pressure head that can go past a stenotic lesion? No. So everything past that stenotic lesion gets robbed from. Right? There's no blood now that can make it past that stenotic lesion. And that's called coronary steal. Coronary steal. When isoflurane dilates healthy heart vessels and steals blood away from diseased blood vessels. Okay? So, you will see this concept on your exam. And try not to learn word recognition, because that may not help you on the exam. It could be a very close definition that says coronary seal in it, and there may be a few things in that definition that are wrong. So make sure you understand what the point is.
Sir, on the previous slide, the COPP, does that mean
Coronary perfusion pressure.
vascular resistance?
Yes. So, I'm sorry. Good point. Is everybody familiar with COBV?
No, sir.
Coronary blood flow is equal to coronary perfusion pressure divided by coronary vascular resistance. Okay. And so normally, just to go over this again, good question. Normally, our vascular resistance, there's some there at rest because we have sympathetic tone. And that sympathetic tone is what allows us to, if you have a heart disease, to push blood past occluded vessels or stenosed vessels. But we give isoflurane, and what do we drop? We drop coronary vascular resistance. And when we drop coronary vascular resistance, well, of course we increase perfusion to the healthy vessels, but that's not the problem. It was the coronary vascular resistance that was helping us perfuse the diseased vessels. And so now we rob to the poor. We rob from the poor, and we give to the rich. So, good question. And in dogs, halothane was given, and they created a heart stenosed lesion in this example. Gave the dogs halothane and gave the dogs isoflurane, compared them. And you see the ST changes in the canine with the isoflurane. And do you know, because of this one study, we have completely changed the curriculum, and I have to teach you coronary seal with isoflurane? Do you think any other studies were done after this? No. This one study.
Is
Yeah.
there any reason that we were using dogs versus pigs?
Oh, this was done a long time ago. And dogs have a, big dog, but has a pretty decent vascular system that's comparative to ours. They weigh about the same. And they were easy to get at the time. They didn't have IRBs back then. You can go to the pound and pick you up about 3 dogs and do these experiments in your basement. I swear to God. I swear to God. We'll never know. Because no one's going to try to do this.
So this isn't something that we would do again with a big model, or we just accept as fact something that might not be.
We don't even hardly use ISO on it. So there's no reason.
So does that mean that the outcome of this, which is Bigger's thing, that again is just a test question, but we only do that when you're using ISO, but otherwise you don't really ever use it?
So in humans, there's never been a documented case of coronary stent.
So we never really do Bigger's, but we just need to know.
Well, Biggers is for epinephrine. And I don't think I've got there yet. So we'll get there. That has to do with catecholamines. And I'm actually thinking about getting rid of Biggers because I hear it's out of the board questions. But we'll get there. Man's reading ahead.
No, because I thought that we gave it because of this.
No. This is a totally different phenomenon. This phenomenon is because of the change in the coronary resistance.
Right, that's why you gave the epi, was to be able to give you that.
No, the epi was given. So what do surgeons like to do with their loved ones there? Right? And so patients are asleep. So when they used to give, and we'll get there, when you used to give halothane and you gave epi with it, you made your patients prone to arrhythmias. And so that Bigger's formula was try to avoid the arrhythmias. It's okay. Well, we have the class. So, in humans, I have not read a case report of coronary stale using isoflurane. However, you'll get to phase 2, and you'll get somebody with heart disease, and you may get somebody that is strictly by the book and doesn't read the literature, and will never let you use isoflurane on someone with heart disease because of coronary stale. If you want to avoid coronary stale, regardless of whatever agent you use, you do the 4HT. You avoid hypoxia. You avoid hypotension. You avoid hypertension. You avoid hypocarbia and tachycardia. Right? The generic consult you get from cardiology when you send your patient over.
So could you say that the current dogma is ISO is contraindicated in cardiovascular patients?
It's not contraindicated.
But
Some people will use it all the time. In dogs, it's probably contraindicated. But
that consult.
if I say ISO, you say Steve. I don't make the board questions. I just try to teach you the content. All right, let's talk about catecholamine release. The first, we all understand catecholamine release, right? Who here remembers the day of rip fuel? Yes.
Wait, we still have those in theaters.
You take it, you feel better because your catecholamines get released, right? Well, the isoflurane and sevoflurane do not release catecholamines. Desflurane doesn't directly, desflurane is not included in that statement. Desflurane will not directly increase catecholamine release, but what does it do when you breathe it in? It irritates you. And since it irritates you, what do you do when you get irritated? You release catecholamine. Right? So now you can see why desflurane makes you spit, sputter, your heart rate goes up, and you get hypertensive initially with it. Nitrous oxide will directly cause catecholamine release. All right. So the first statement on there is true if you're talking iso and you're talking sevoflurane. It's also true of desflurane if the patient's already asleep. But if they're breathing it in or you're changing concentrations quickly, it will irritate you and you will indirectly then cause catecholamine release. Does everybody see that distinction? Okay. Now, this graph talked about the effects of halothane and the old drug enflurane on ventricular ectopy. So when you look at the top graph, and again, in surgery, surgeons like to use local anesthetic, and they like to put epinephrine in their local anesthetic to extend the effects. And using the older drugs, enflurane and halothane, it was found that when you started using this epinephrine, you would promote ventricular ectopy in the patients. And so a study was done on it. That study, or one of them, showed that the microgram epinephrine dose, as it increased the number of ectopic events. So now let's look at some of the drugs that we currently use in the bottom chart. Do the drugs that we currently use, the isoflurane, sevoflurane, and desflurane, does that cause cardiac dysrhythmias? And so in order to cause a dysrhythmia, I want you to use in humans, the way you read this is the average dose of epinephrine to promote not a lot of it, just promote ventricular ectopy. There's no number here, but an event of ventricular ectopy. How about that? So the average dose of desflurane in humans is about 7 mics. But if I were to ask you, of all the modern anesthetics, desflurane, sevoflurane, and isoflurane. In humans, which anesthetic, based on that experiment, has a lower threshold for ectopy when using epinephrine? Desflurane. It's a lower threshold, means it's easier to cause using epinephrine.
I'm sorry, man, I don't quite see how to read these charts together.
So I got that backwards. You're not reading these together. You're not reading them together. They're separate. Did I just tell you that backwards? I think I did. Let's look at this again. The average dose to cause ventricular ectopy. Yeah, the easiest one. I'm sorry. The easiest one would be sevoflurane, the one with the least threshold. The one where it's hardest is desflurane. So once again, if I were to ask you, let's get that question right, Bentley. What modern anesthetic, when a surgeon uses epinephrine, if a surgeon uses epinephrine and you're using sevoflurane, you might see some ectopy. That's better. You might see some ectopy. So the cardiac dysrhythmic dose of sevoflurane.
Am I reading this incorrectly? The title being cardiac dysrhythmia dose of epi. You're giving epi in order to prevent ectopy.
No, you're causing a dysrhythmia with the epi. This is the dose of epi that causes the dysrhythmia.
Okay.
And so the dose that causes a dysrhythmia for SIBO is roughly 5. For ISO, it's roughly 6, and for DES, it's roughly 7. Yeah.
That's the surgeon pushing low.
Yes, that's the surgeon. This is, the surgeon's going to use local epi all the time.
Is that true also for, like, say, if you're wearing maybe use a compressor, use a different chemical, like using aspirin?
I don't know.
It's just so low with epi?
This is the only thing, this is just with the X. And the only reason they started doing this is because they saw that, why did they start doing this, and why do I have to teach you this? Because when they started using halothane, surgeons were given epi at the end of the procedure, patients were having bigeminy, multifocal PVCs, and they wanted to know why. And then they started comparing the drugs, and that's that pop crap. And so somebody in Barish, the last edition, said that let's look at the modern anesthetics. And I have a feeling that they put the graph like they did because it's very rare to see a surgeon give epinephrine now at the end and see this dysrhythmia. But apparently they did it in humans and found that if you gave 5 mics per kilogram of epinephrine with sevoflurane, you might see some ectopy. If you gave 7 mics per kilogram of epinephrine while using desflurane, you might see some ectopy. I should have explained it better. That's what I meant. And I want you to take figures and be the first class to ever cross it out.
Sorry, on the last slide. You said humans, not animals, right?
Humans.
So wouldn't it be DES?
This-
Because DES is higher.
It takes more epi to cause a dysrhythmia.
So how would it produce?
But it's almost the same as ISO. It's very, you have to be really detailed on that.
I know.
Yeah.
I'm not disagreeing.
How would a biggers help?
So,
the old days of why you need biggers was to synthesize them.
So, I'm not going to test you on this. So, if you want to listen, great. If you don't want to listen, take a break. So, this will help reinforce it a little bit. So, I had to learn in your seats this Katz and Biggers formula. And so, the scenario for me was, all right, student nurse anesthetist, you're using halothane in your case. Yes, sir, I understand. The surgeon is going to ask you how much epinephrine they can give the patient at the end of the case in their local anesthetic. Yes, sir, I got it. So how do you calculate that? That's what that is for. If you want me to go through it, I will. Okay. But you can cross it out. I'm not going to have you do a Bigger's calculation.
Do they still do that now? Sorry. Do they still calculate that out?
Nope. Nope. And if they are, that's just some old fogey that's messing with you. Because it's not on the board anymore. Maybe I'll ask you this. If you're ever using halothane and you're in the field and the surgeon asks you about epinephrine, what formula are you going to have to look up? Is that a fair question?
Yes.
Okay. All right, here we go. Let's put the catecholamines to rest. True or false? Desflurane increases catecholamines.
Indirect.
That, I asked you true or false.
False.
True. True.
Did you repeat the question? Well,
No. No. There's no well there. It's a true or false statement. Does it, if you administer it, does it increase catecholamines? Yes. I didn't ask you the reason why.
Yes.
Well, it depends how you administer it, right?
No.
All right. This is a good learning tool. It's all right. You guys are so smart that you're adding all of these imaginary words that don't exist in the question. You're so, but what if? But what if? Hey, no. True or false? Yes or no? True. Right. If it's a little bit true, it's got to be true. If it's false, it's false. Now, true or false? Does desflurane directly cause catecholamine release?
False.
That is definitely a false statement.
false.
Yeah. Right. Isoflurane. Does it increase catecholamine release?
No. False.
Does it decrease catecholamine?
Yes.
That's true. You know? So,
Can you do a logical conversion on a true or false question?
but I don't. You guys gotta trust that your first instinct is correct. Don't go back changing answers. All right, it's another 30 minutes. Let's talk about HPV. HPV.
The HPV I'm thinking of doesn't seem to apply to respiratory.
No, it's not. So, it's not the human papillovirus or whatever that is. This is hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction. So, it's just what it says. When you become hypoxic, your pulmonary vasculature vasoconstricts to help you better manage your VQ, right? Who here is not familiar with VQ? You can say it. I was an OB nurse in your seats, guys. I knew magnesium and Pitocin, so that was it. And I knew fetal heart rate tracing. That was it. So VQ is ventilation, Q is perfusion. And this is kind of like the distribution of ventilation and perfusion in your lungs. And so, think about this. Ideally, you would like that ratio to be 1. You would ideally like to match your ventilation with your perfusion. Okay? You'd like to have 1-for-1 liters per liter. You can have a great interface there. But things happen. If you become hypoxic, let's say you got a dead lung unit. There's an obstruction in there. What is your V now? It's 0. If you don't have any ventilation going in there. So all of that blood that is passing that dead alveolus, that's a waste. So what does the body do? Hey, this alveolus is dead. I am constricting this area, and I'm going to shunt this blood to an area that is better ventilated to help move my VQ ratio closer to 1. Everybody seeing that in their mind's eye? Okay. That's a quick down and dirty on VQ. You need more help, come see me on that. All right, so what do you think your inhalational agents do to blood pressure? And in order to drop blood pressure, what do you have to do to vascular smooth muscle? It has to relax. Not just some vascular smooth muscle, but all of it. Are pulmonary vessels vascular smooth muscle? They sure are. And so when a gas hits those pulmonary vessels, what do? They dilate. So now you can't shunt that blood. And now you're just, you're staying unoxygenated because now you're passing through this dead alveolus. It's not getting any ventilation. Okay? So ideally, or what will happen then, think about this, I tried to give you colors to help. You get this area that is perfused but not ventilated. Perfused but not ventilated. And so the blue blood stays blue, right? And it mixes in with oxygenated blood. And that's called a shunt. Everybody seeing how that turned purple? Okay, so that's called HPV. All of your volatile agents will inhibit HPV. All of your volatile agents will inhibit HPV. HPV is a normal response. Anesthetics will inhibit that normal response. Questions? Okay. Now, if you follow Barish or Stoltine or Miller, you see that they jump around like this. So there's no good system to present these factoids to you. So I just have to present them as they come. I want to talk to you now about CMRO2. CMRO2 is the cerebral metabolic rate of oxygen consumption. Cerebral metabolic rate of oxygen consumption. What do anesthetics do to nervous tissue? They depress it. And if tissue is depressed, does it have as much of a need for oxygen? It does not. So it makes sense that the volatile anesthetics will reduce CMRO2. And that's a protective thing. That's neuroprotective. Okay? Anyone here used EEGs? You start to give these agents, and they will cause in the EEG isoelectricity, meaning a flat line, meaning that you've reached your maximum effect of your inhaled agents. Now, we said that these agents will decrease CMRO2, but the blood flow is a little uncoupled from that. When you hear the term uncoupled, I'm using these terms for a reason because that's the way it's referred to in the book. That means that the blood flow is opposite. So, for example, desflurane will decrease CMRO2 by 50%, but increase cerebral blood flow by roughly 20 to 25%. Okay, so think about what that does for the neuro patient. That's a good thing. You're providing substrate and decreasing the need for that substrate. And you're increasing your cerebral perfusion pressure by decreasing cerebral vascular resistance. Tracking?
This might be a little bit of a weird question.
No weird questions.
Since we developed the concept of MAC to give us like an endpoint of anesthesia,
Check.
if we can quantitatively see on the EEG cerebral depression, why is that not like the standard endpoint instead of that?
Okay. So, isoelectricity is far beyond 1 MAC.
Oh.
If you make someone isoelectric with a volatile anesthetic, That is way beyond 1 Mac. Way beyond 1 Mac. You're still going to have EEG activity even in anesthesia. Who here has used the BIS? It's a component, and you see when they're sedated, there's still electrical activity brain-wise. It's not an EEG, but it's a comparison. Yeah, to put someone in an anesthetic coma with that is much greater than that. Good question, though. I'm not going to ask you which drug does it the best. The point that I want you to know is what? If I give 1 Mac of an inhaled agent, I'm going to increase or decrease my CMRO2. Decrease. And then what am I going to do to my cerebral blood flow? Increase. Right? And that term is called uncoupling. You increase cerebral blood flow, you decrease CMRO2. And that's protective for the brain. Yeah. So I give a MAC of agent, whether it's DES or SIBO, and I'm going to decrease my CMRO2 while simultaneously increasing my cerebral blood flow. That phenomenon is called uncoupling. And, well, uncoupling is a generic term, but in this instance, it's just a divergence of 2 directions. I think I nailed that point. Okay. Got that? Let's talk about cerebral blood flow. Cerebral blood flow. What do you mean by this slide, sir? Here's the point. Inhaled agents will have a decrease in cerebral blood flow, right? That's given. However, if we don't control CO2, we're not going to interfere with the ability of CO2 to further increase cerebral blood flow.
Said in the last study, increased.
CO2?
Cerebral blood flow is increased by agents.
Yeah, that's what we're saying the same thing. Cerebral blood flow is increased by agents on their own. Got it. This is I'm talking about the ability of CO2 now to affect blood flow when I'm using agents. Inhaled agents inhibit a lot of things, but not the ability of CO2 to cause further decreases in cerebral vascular resistance and increases in cerebral blood flow. That's all I'm saying with that slide. What's the point, sir? The point is this. If you've got someone who you're not controlling their PaCO2, I want you to think head injury here. I want you to think, okay, sir, I'm using the uncoupling of these agents to my advantage. But an increase in cerebral blood flow has its limit. If it gets too high, it doesn't matter how much you decrease the CMRO2 because you're not going to be able to perfuse the brain because the ICP will have went so high. So the point here is you're going to have to monitor your CO2 levels and keep them normal, right, to take advantage of that uncoupling effect. Otherwise, if you let the CO2 creep up, you're literally going to increase your cerebral blood flow to the point where your cerebral blood volume gets large and your head explodes. Not really, but... That's the only point I'm trying to make there with that CO2. Yeah.
So they're additive.
They are. They're additive. Well, why'd you even add that, sir? We know it's additive. Well, when I read that in Varish, it didn't make sense to me. Why were you adding that? So when you read this, that's what they're saying here. And how are you more than likely going to control the head injured patient? Mechanically ventilating or spontaneously ventilating?
Mechanically ventilated.
Exactly. Just a quick primer on ICP because I had to add this for a couple questions that had come up in the last classes. Because there are people like me that were OB. All I knew was birth and babies, nothing else. So ICP, this is going to be a graph that some of you know, some of you don't, but you will. And what it says is that as intracranial volume increases over time, that at some point intracranial pressure is going to rise. And I added this slide juxtaposed to the last slide to illustrate the effects of increasing cerebral blood flow. If I keep pushing blood into the brain, it's going to get to a point where my ICP is going to start rising. And then at that point, the brain is either going to herniate down through the foramen magnum, or you're going to compress it and have a lateral shift one way or the other. It's just going to be bad for patients. So we want to control CO2. And then I added this. This is just an extra for you guys to illustrate why we like to keep our patients eucapnic. They have not really anything to do with gases, but a nice little tidbit here. If I start hyperventilating you, and I keep you hyperventilated at a CO2 of about 20 for 8 hours, eventually that becomes your new normal. And then if I go from 20 and I all of a sudden make your CO2 40, that's not a good thing to do acutely. All right? That's not a good thing to do acutely. Well, sir, why are you even bringing up hyperventilation, ICP, all that stuff? Well, because we're talking about cerebral effects of the gases. Why would you, maybe acutely for an hour or so, hyperventilate someone?
On the way to the OR for their cranium.
To decrease intracranial pressure with some acute vasoconstriction. But if you continue it, then eventually the vessels lose their responsiveness. And now, if you stop them acutely, guess what happens? And it goes back up to 40, they vasodilate, and now the ICP skyrockets. So that was the point of that. This is the only time I'll ever ask you about enflurane. When I say enflurane, you say seizure. Enflurane, seizure, enflurane, seizure. Thank you. Any questions to date on what we talked about?
Why is that?
Why? Because of all of the alkaline anesthetics, it appears to have a lipogenic effect. There's your answer.
Okay.
Boom.
And I think that's still asked on the board, so that's the only reason I put that slide up there. How many slides we have left?
About 38.
All right, we're done for today. I'm closed.
Thank you very much, sir.
Yeah.
I just had one of the only guys that missed it. Or it was right in the additive effects in here. Someone shot it off the end.
For the test tube. Disease. Oh, we're still going.
And is that just if you and then increase parameters? I'm sorry, just the change part that you is also but then you can track the whole thing. They just move the items.
You can never remember what to do in that forest.
Can you send me your calendar